Hello, hello.
Hey, what's up, Andy?
How are you?
I'm good. Come on in.
Thank you so much. Well, how does it feel to be the second to last 73 question interview in my series?
You know, it's an honor, it's a privilege, and it's a lot of pressure.
There's no pressure at all. I could not think of many people better at all. You have an incredible story and a really, really awesome specialty. And I think the world is ready to hear about it.
Thanks, Andy.
Are you ready?
I'm ready.
Let's get started. So what is your name?
I'm Paul Tran, and this is my story.
Well, what's your specialty?
I'm a pediatric gastroenterologist, or a GI doc.
And how many years out of training are you as an attending?
I am almost exactly a year and a half out of training. So I started last July, right out of fellowship.
Righty. So where did you go to undergrad?
I went to Duke University. I'm a proud Blue Devil.
And medical school?
At the University of Colorado School of Medicine.
And how about residency and fellowship?
Residency took a quick foray down to Texas and Dallas. 3 years there at UT Southwestern, and then 3 years back in Colorado at Children's Hospital, Colorado.
Alrighty. So I know you get to interact with a lot of medical students. So what was your favorite part of medical school?
Favorite part of medical school? Oh, you want some coffee?
Absolutely. I can never say no to coffee.
Okay, awesome. Favorite part of medical school? Honestly, medical school for me was like my college. I just had a really, really good time. I worked really hard. I think I played really hard. My favorite time of medical school, honestly, I would say one of the most memorable things and favorite things overall, 4th year of medical school was, I think, just an amazing experience. Between the sub-Is and really like putting on the hat and being like, this is my career, let's see what this is like, to the actual interview process. And I was lucky, I got to do in-person interviews. I got to fly around the country and do in-person interviews. That was really exciting. And then kind of the most expensive vacation you ever take in the second half of 4th year. I think that was really cool. I think, overall, here's yours.
Thank you.
I think if I had to choose one memory though from 4th year of med school, it was my first rotation, which was pediatric GI as an elective. Walk in, I'm a brand new 4th year med student. And really at the end of this rotation, I had done, I think 8 or so upper endoscopies or EGDs, because one of the attendings had just said, here, take this scope. Like, we're going to teach you how to do an endoscopy. And if you want to hook a medical student to your specialty, like, give them a procedure to do. Have the patients to walk them through a procedure and actually do it. And wow, like that really got me hooked on pediatric GI so early. And I was like, this is the field that I want to do. I knew from the first month of 4th year of med school. So that's probably one singular experience I can think of.
Well, prior to that 4th year experience, what specialty did you think you were going to go into on your first day of med school?
Honestly, I had kind of a roundabout journey. I came in thinking pediatrics because of some experiences in college when I was shadowing actually a pediatric geneticist. I became drawn to pediatrics. I knew I really like working with kids. I really like being able to counsel families. I think that was something that was fulfilling to me. I came in thinking pediatrics, and then I took like probably a 1.5 year or so dive into ENT. I thought pediatric ENT is really exciting. I think that's honestly something that I think a lot of reconstruction could be really interesting. Cleft palate repair could be very interesting for kids. And then kind of went right back to pediatrics during 3rd year rotations. I'm like, okay, that's where I settled in.
What changed your mind about the Peds ENT world?
honestly the kind of culture environment of the OR to me. You know, I've always was someone that really appreciated working with my hands. I really liked both. To tell you the truth, I was interested in ENT and pediatric ENT because I heard you could do clinic, you could do procedures in clinic, you could have that kind of hybrid. You know, I wish I had learned more about surgical specialties like urology as well. But I think I was always someone that liked that hybrid, that versatility. And I felt like just surgery in general, it didn't allow me to do some of the things that I liked. I honestly liked some of the rounding stuff. I liked some of these kind of nuanced, esoteric concepts. Not a lot of it, you know, not all the time. But I liked being able to kind of flip between them from a day-to-day mindset, so or perspective. So I think, honestly, like, I think the thought, it's kind of a med student thing, but the thought of standing for the rest of my life like this, it didn't appeal to me. Obviously, you're not like just standing there. If you're the surgeon in the OR, you are performing surgeries too. So, but that was my perspective as a med student. I'm like, I just don't want to stand in the safe zone like this, away from the blue sterile field all day. There was something really sterile about the culture of surgery.
Yeah. Oh, were there any specialties you immediately said, not for me, even like before you experienced it?
I think, honestly, I think radiology and pathology, to me, I was drawn to medicine because of that real conversation. And I work alongside, as a gastroenterologist, I work alongside radiologists and pathologists so closely right now. I mean, they're probably two of the specialties I interact with on a day-to-day basis, to tell you the truth. So absolutely taking nothing away from those specialties. I rely on them to do my job well. I just really think that personally, I crave that conversation with patients and really being able to sit down and like look someone in the eye and say, hey, you know, I'm here to listen to you. That to me is something that really draws me to medicine and I find really fulfilling. So I think those things I kind of nix, knowing, okay, patient contact, or at least how big of a proportion of that is my practice. That's something that that I think I knew right away. And then just purely from an interest standpoint, you know, I think OB-GYN, it's just something that I think I enjoyed parts of my rotation. I enjoyed delivering babies. I mean, I think a lot of pediatricians say that you're like in the delivery room, you're more drawn to the baby than the mom, you know. I think that's where I was. Not for any particular reason though.
Gotcha. Oh, bring the focus back on pediatric GI. How long does your training take after med school for those interested?
Yeah, so pediatric GI is it's total 6 years. So 3 years of pediatric residency and then 3 years of pediatric gastroenterology fellowship. Generally, that fellowship is interesting. It's like some other specialties, cardiology, pulmonology, similar to internal medicine. It's just in the pediatric route. You do about 1 year or so of clinical medicine and you do 2 years of research. It's really interesting because honestly, some people are like, I don't really know about research as part of my career, but that is something they equip you to do, be able to work in an academic environment. So they give you research skills, even if that's not something that's the rest of your career going to be a focus.
Gotcha.
Yeah.
So,
want to go outside?
Oh, sure. It's a beautiful day outside.
Yeah, my kids are outside, so I'm gonna make sure they're okay out here.
We'll make a little guest appearance.
Yeah.
You got quite the setup back here. See, you're training a 5-star athlete in the back.
Yeah, that's right. You know, just a little bit of football, soccer goals, and basketball hoop for them.
Exactly. All right. Well, did you consider getting any other degrees, like an MBA or an MPH at all?
I didn't for those. I very, very, very strongly considered getting a master's of medical education. I actually have a master's in physiology, so I did do that during the year, a gap year between medical school, or between college and medical school. But I think, it's kind of imminent. I'm going to get a master's in medical education because med ed is just, it's just something I honestly live and breathe every single day. So, yeah, that's probably something within the next 2 years or so.
All right. Now let's try to sell your specialty to the brilliant pre-meds and medical students out there. So why should someone choose pediatric GI?
I think pediatric GI, so within internal medicine or pediatrics, GI is such a versatile field. You have versatility, and variety is honestly the spice of your professional life in this field. So I can spend, let's talk about variety of conditions that you treat. So instead of focusing as a subspecialist on one organ, I can choose to focus on something like the esophagus alone. The esophagus, the stomach, the small intestine, the large intestine. I can be an IBD expert and think about Crohn's disease anywhere from the mouth to the bottom. I can think about just ulcerative colitis, just the colon. Or I could be a pancreatologist and think about the pancreas. A hepatologist, think about the liver. So you can diversify or specify within a kind of complex set of organs, which I think is really cool. So you can get even deeper. We can see conditions in pediatric GI. We focus a lot more on nutrition and growth. That's one of the main things. I think that's the difference between adult and pediatric GI, which is there's a lot less screening in pediatric GI and a lot more focus on potential growth, development, nutrition. So we can see that. So anywhere from babies with malnutrition who are not growing well with severe GERD, to constipation, to the things that honestly adult gastroenterologists see. We do see gastrointestinal tract cancers. We see GI bleeding. We see emergencies, button battery ingestions. We see different things that we need to think about acutely. That brings in the procedural aspect. I can, during my week, I can be in clinic one day, and then the next day I can be in procedures doing endoscopy all day, and then I could be on the inpatient wards. I could be in the PICU or the ICU. I could be in the NICU seeing babies. I could then go back to clinic. I could go teach. I think that is amazing. I'm not just in one practice environment. I span the entire hospital. And you honestly get this really cool spectrum of interact with surgeons, interact with neonatologists, interact with other subspecialists, interact with general pediatricians. You are wearing all of these hats, and it's in the spectrum of, or the breadth of, one field. So I'm not a jack of all trades like an emergency medicine doc or a general pediatrician, where I need to know really a lot of everything. I can focus on my specialty, but then within that do a variety of things, see a variety of conditions. I think that's really, honestly, amazing. And then honestly, the quality of life is really good. For the most part, so I am actually in a unique role where I'm a GI hospitalist, so I'll be doing a lot more inpatient time, and almost exclusively inpatient time. That's not the typical job, but generally, the field allows you to see patients in clinic, and then when you're on call, you are on call for emergencies, really GI bleeding and foreign body ingestions that happen a lot in kids, where we have to fish things out. Other than that, though, you're not really staying in the hospital on call all the time like a pediatric surgeon maybe. So I think it allows you, I found kind of a balance for shift work. Where that's possible in the field. Honestly, I think those things about the job itself, and then as a profession, the longitudinal nature where you can form a relationship with a patient as a brand new infant all the way until when they're 18 and sometimes a little bit older, that is really, really valuable to have that relationship, especially when we see a lot of chronic conditions in the world of GI. Growth is not something that you see for one visit and then you're done. We see babies sometimes every 1, 2 weeks, 4 weeks for a period of time. So that really allows us to develop, honestly, really meaningful relationships.
Sure. Well, flip it around. Why should someone not choose this specialty?
I think one of the things that you need to recognize about especially gastrointestinal complaints or issues, pain, nausea, even vomiting, these are things that we see a lot of. There's not always a quick fix. If you are a cut it out and forget about it kind of person, sometimes that doesn't really help. And sometimes you have to be able to be uncomfortable with not knowing or comfortable with not knowing, really. So there is a degree of mystery sometimes, and there has to be the ability to kind of recognize your limits. And I think sometimes saying like, I need some time to figure this out, or I don't know right now, and I have some ideas, and what are the risks and benefits of the procedures that I can offer, the treatments that I can offer. I think being able to have those discussions takes a lot of time. And I think if you really want to do the job well, you have to spend time. And if you're kind of like, I need results right now, that this might not be the field, for you.
It's a very good perspective. And I will say the little gurgling noises of the pool cleaner, if you're not a fan of that, I don't think you're going to like endoscopy or colonoscopy. So if that grosses you out, I don't think GI should be on your radar.
It's funny. Let's go inside. I feel like it's a little bit cooler than I thought. It's a good point, Andy. You sometimes you choose to do medicine based on the types of secretions or noises that you can handle. Like, no joke.
Yes, that's true.
We talk about it all the time. I can deal with poop. I can deal with puke. I can deal with bile. But the respiratory secretions, when you got that loop sound, I don't know.
And I'm dealing with the other end secretions. You take care of that end, I'll take care of this end. We all have our job, and we'll be happy at the end of the day. All right. So now we're gonna get a little bit more into your day-to-day. And I know we touched on there's a lot of variety in your job. So I know this might be a complex question, but what does an average day look like for you?
Yeah, average day. Let's kind of say for a traditional gastroenterologist, I think the average day looks like primarily clinic-based. So you kind of wake up in the morning, you might go and look at your schedule for the day and see, again, a variety of conditions. So I'm going to see a baby for reflux symptoms, and then I'm going to see a baby who's not gaining weight and for malnutrition, and then I'm going to see a teenager for concerns of bloating and abdominal pain. And then you kind of look at your schedule for the day, you review, look at charts that come in. We're consultants, we're subspecialists, so usually there's a referring general pediatrician. I've seen this patient, I think they need specialty care. So we get referral documents and we review those thoroughly, and then we see our patients. And generally, for me, it's an opportunity to educate. And I have a mission statement, which is really focused on patient care and then focused on education, and they're very similar. To equip and empower patients to be advocates for their own health, to equip and empower students or learners to be advocates for their own education. That's my personal mission statement. So I really embody that in clinic. And I think a lot of my colleagues and a lot of people, especially in GI, embrace that education role. So in a clinic visit, I try to get as much history as possible. I try to use any labs that have come in, and then I sit down and I try to take at least half of my clinic visit to explain thoroughly. Hey, I'm really worried about this. I hear what are called red flag symptoms, or I'm actually not quite sure of what could be going on. or of what definitively is going on, but here are some possibilities. And I try to outline everything. I try to draw pictures wherever I can. We use dry erase markers, and I try to draw diagrams and pictures. That's one of the cool things about dealing with the GI tract. I think explaining where things are and where certain symptoms could be coming from is really exciting and elucidating. And then I try to come up with a proposal for a management plan. It's not the definitive plan sometimes. Sometimes I look at a family and say, hey, look, there is no right answer here. I learned from a mentor, sometimes you're not choosing the best approach, you're choosing the least bad approach.
Yeah.
There's not really a good answer sometimes, but there's bad approaches, and then there's like, okay, this is not good, but it's less bad.
Perfection is the enemy of good enough.
Yeah, I think sometimes. And I think explaining that and just explaining risks and benefits sometimes, and then kind of moving on from there to, making sure there's a plan that we all agree on. Absolutely. And then moving on to the next patient. So that's kind of the clinic day. Again, in the world of GI, we get a cool day of procedures. So one day a week, you might be just in the endoscopy suite, and we might do what's called EGDs, esophagogastroduodenoscopies. So upper endoscopies, looking at the esophagus, the stomach, the small intestine. We might do colonoscopies, looking at the large intestine or the colon. We might do, in training, we did liver biopsies. We did procedures like manometry to look at how the nerves are squeezing. So there's a variety of conditions that we look at and a variety of procedures that we can do. And generally, you get to do that for the most part every week. So that's kind of the traditional outpatient. And then really inpatient, it's going in and seeing patients who are admitted in the hospital, rounding, similarly looking up information, rounding, visiting each patient, family. And then as a subspecialist and subspecialty team, we do a lot of consultations. So the NICU may call on a baby that might have a gastrointestinal complaint. The general pediatrics team may call for a liver complaint. So we see these patients around the hospital, and we give recommendations.
Of course. Alrighty. So how many patients do you see in an average day?
I think that really depends. I would say we get a little bit more time from a specialty standpoint. Man, it varies. I would say probably 10 to 20 is probably the average.
Okay. And I know you mentioned it can be outpatient and inpatient.
Yep.
For you, which one is it mostly?
Now it will be primarily inpatient.
But it's good to know you have that option. What's the most amount of patients you've seen in a day?
It's probably got to be inpatient. I'd probably say 25 or so.
Sure.
Yeah.
And I know you mentioned this a little bit earlier, but what are some of the most common procedures that you get to do?
I would say bread and butter for us is a screening EGD or a colonoscopy to really look for inflammatory bowel disease. We are not looking for cancer surveillance, screening colonoscopies. We do diagnostic colonoscopies. So that's why we generally do fewer colonoscopies than an adult gastroenterologist. And we do primarily a lot more EGDs. We're doing them really for clarification or elucidation of possible symptoms. What is the cause of this persistent vomiting? What is the cause of this epigastric pain? One of the things that I really do, I feel like I'm really drawn to, is the acute procedures like GI bleeding. I think that requires a lot of technical expertise and confidence in new techniques and new tools available. But you really get to make a difference. I mean, it's an urgent or emergent procedure with sometimes dire consequences if left untreated, and we get to come in and get to intervene on that. But the great thing is having the confidence to know that we are actually not the last option. we're the first option. And if we can treat it endoscopically, we save a lot of bad outcomes, and we can really do non-invasive or less invasive techniques or save that. But there's an interventional radiologist who can coil or embolize arteries for arterial bleeding. There is a surgeon who can surgically ligate. If I'm unable to control bleed, I know there are other options. And I think that's freeing.
That is a very new perspective that I did not have on this field, and a great point to anybody considering this and like what role they want to have in kind of like just the treatment algorithm as far as like you want to be in the front lines or a little bit further down.
Yeah.
Awesome. So really quickly, I know you can go on and on about this. What is the most common diagnoses of problems you see patients for, particularly that are unique to the pediatric patient population?
Yeah, I think infantile reflux. So GERD in an infant is probably, it's different than GERD in an adult. Cow's milk protein allergy or cow's milk protein intolerance, which can have some symptoms that mimic GERD. I would say, so oral aversion, especially in an infant or young child. So a kid who just stops eating, refusing to eat, or not taking enough to grow. Those are things like you think about older patients with stroke who have difficulty swallowing, you might see that, but we don't see that really generally in the pediatric population. I'd say by far and away, the most common thing that I've seen is constipation. And then, I think there's a realm of disorders of gut-brain interaction that we see. I think a lot of people think about IBS in the especially teenage adult population. We see some of that. We see something called functional abdominal pain, which IBS is associated with really stooling symptoms, and functional abdominal pain is really just kind of can be debilitating abdominal pain, but it's really pain in the absence of stooling symptoms.
Gotcha.
Those are some of the things we see.
Okay. So it's a fun question, especially I'm interested in the GI world because we have a lot of med tech involved in GI. Yeah. What are some emerging tech or advancements that you find exciting or promising?
I think the buzzword being AI, I think there's a lot of incorporation of AI really in endoscopic techniques. I think, again, adult gastroenterologists are really pushing the envelope, I think, quicker than pediatric gastroenterology, which sometimes lags a little bit behind just because of sheer volume and need. But AI within even cancer surveillance techniques, I'm hearing a little bit about, which I think is really cool. Generally they revolve around endoscopy focuses.
Gotcha. Oh, now this is gonna, I don't mean to repeat the word, but a tough question. Okay. What is the toughest part of your job?
I think the toughest part of our job is also what I mentioned as part of the most rewarding thing in a draw that would sell you to this field. It takes a lot out of you. It takes a lot to really not know the answer sometimes, or to not have a quick fix. If we could offer a quick fix for every single patient, if I could do that for every single patient, I would 100 times out of 100 do that. But a lot of the things that we see don't have quick fixes. So to be able to spend the time to fully explain that, to fully talk about risk benefits of invasive procedures versus not, to come up with a mutual plan with a family can be really difficult, especially when you have pressures of time. And I think whether you're in clinic or in the hospital, spending the time and giving every single family and every single patient the time, the energy, and honestly the attention, focused, unwavering attention needed, can be really, really draining. and it can demand a lot of you. And I think we have to do it. That's part of I think that's part of the expectation of care. I think that's the agreement that I'm making, that I'm going to give you the best care that I possibly can, but it takes a lot out of me. And especially when it's difficult conversations, it's dealing with frustration. Sometimes patients are coming in with years and years of feeling like they're not heard, years and years of feeling like no one knows the answer. And I don't know if I know the answer. I don't know if I can offer anything different than what someone has heard multiple times. But I know what I can offer is attention, time, transparency, explaining things that, like, this is my first impression. This is what I think. That is something that I think it really is something that can be very difficult to sustain for long periods of time. So I think finding ways to make your career sustainable and fulfilling are really vital.
Yeah, and I'm sure there's additional pressures as well working with children, parents, where arguably the stakes are higher, but I think the patience, the time spent, goes even further for these patients and worried parents, because that's their little baby that you're taking care of.
Yeah, I mean, as a dad myself, I use my experiences a lot as a dad. I have 2 toddlers, essentially, or a toddler and a young school-age kid, I guess. And I always say I thought that being a pediatrician would make me a better dad, but it's completely and utterly the other way around. Being a dad has made me an infinitely better doctor and pediatric gastroenterologist, because I understand. I might not understand exactly what a family is going through with a particular condition or something with a child, but I understand what it means to be a parent and to understand that perspective and to have that anxiety and to have that worry and to want absolutely the best for your child and to do whatever it takes to have the best for your child. And I mean, I have been there in terms of general GI complaints. I know what it's like to have really, really, really bad, or a child with really bad constipation. And like, I've told families all the time, like, I tell them that story that, I had to do that with one of my own sons or deal with that. And I'd be like, is this a test? Like, I thought this wasn't supposed to happen. I'm a pediatric GI doc, but it just illustrates how common it is. Yeah.
So, but before we go into some numerical questions, I can't leave us on like what's the toughest part of the job. Flip it around. What is the most rewarding part of your job?
The most rewarding part of the job is when you spend that time. When you spend that time with a family, with a patient, and they know that there was someone who listened. Yeah. There was someone who spent the time. There's someone who didn't want to just wave and sweep complaints or concerns under the rug. There was someone who maybe readily admits that there's not a good answer or they don't know the best answer, but is transparent about that. I think when families experience that, I honestly think that's one of the best parts of my job, to be able to provide that level of care. And honestly, as someone who loves education, really it's when I can spend that time and have a family or a parent look at me and say, I have never heard that, or I've never thought about that before, or like that makes so much sense. And when that light bulb moment goes off, or the light bulb goes off, and I could help them get there. Like that to me is so rewarding.
Yeah. Well, could not agree anymore. Obviously, I'm biased. I have a heart for working with the pediatric patient population, and having that share of joy between you and just for a moment, just for a second, you're a little bit part of their family. Is like that's what a wonderful experience.
Yeah, that's why pediatrics for me. To me, it was a double the responsibility. You have two patients. You have the child, you have the family. You could give a plan to the child, like it's their caregiver, their family, who's going to be able to follow that through. So you have a responsibility to educate and to empower both your actual patient and then the people who are taking care of them. But then you get double the fulfillment with that. So,
amen. All right, let's knock out some of the like more, okay, fine, boring, but number questions.
Okay.
How many hours do you work in an average week?
In an average week, I'd probably say truly, I'm at the hospital most days between 6 and 6:30, and I'm probably not leaving till 4 or 5 at the earliest. I'm gonna guess 50. Let's call it 55 hours.
Okay. What time do you normally wake up?
I usually wake up at you can call it 5.
Right. How many hours of sleep are you typically working on?
I would say probably about average about 6.5 to 7.
How many hours of sleep are you working on right now?
It's a weekend, so 7.5.
Oh, it's a good day.
Okay.
So, I know you touched on this earlier, but of course, still worth mentioning. Do you have to take call?
I do, and my job now is only call.
Any opportunity for even further subspecializing, if you would like?
Well, 100%. So that was actually one of the things that drew me. Again, what drew me into GI was actually the procedural component, and for I would say the vast majority of my training from most of residency when I was committed to GI through the vast majority of fellowship. So at least 4.5 years of my training, I was gung-ho committed to what's called advanced endoscopy. Now, advanced endoscopy or therapeutic endoscopy is doing procedures called ERCPs. Primarily, it's pancreaticobiliary procedures. Endoscopic retrograde cholangiopancreatography or pancreatoscopy.
Wow, you pronounce every syllable in that. That's impressive.
I might have butchered that now. Like if I now see what I just said, it's probably incorrect. But essentially, it's specialized procedures to get into the biliary tract for choledocholithiasis or stones in the plumbing of the bile ducts. There are honestly at this point probably still fewer than 50 pediatric gastroenterologists who do these procedures in children. There are some adult gastroenterologists who perform these procedures, but even in internal medicine gastroenterology, it requires an advanced fellowship. So you can do those procedures. Again, like I said, you can specialize in different organs. Actually, transplant hepatology is another further fellowship. So people do a 1 to 2 year fellowship following their pediatric GI fellowship.
So plenty of options.
Plenty of options, yes.
Alrighty. So before we go into the life side, the Paul, not Dr. Tran side of things, what's the most common medical advice you give to your patients?
Yeah, that's a good question. Man, I feel like I give a lot of advice. Maybe sometimes overly. I would say, I say a lot. Maybe this is not the most, but I say it a lot that this won't be forever. So don't think about this as forever. What I sometimes tell families and patients is like, don't let your condition or your illness define you. You are John with ulcerative colitis. You're not ulcerative colitis.
Mm-hmm.
You're not marked by your chronic condition. Or if it's unknown what the condition is, you are not marked by the symptom. You're not marked as debilitating abdominal pain. You are a person with interests, with experiences, with feelings, with emotions, with visions, dreams, hopes. Don't let that define you, and this won't be forever. This may be for a long time. This won't be for forever. And I think it's just a way to help reframe, priorities and what's important.
Yeah, that's wonderful, man. Oh, all right. Let's put on the Paul hat.
Okay.
So, what is your favorite thing to do when you're not working?
I am a sports fiend. I love watching sports. I love football, American football. I think so. A big hobby for most of the year is actually fantasy football. It allows me to be super, super nerdy and think about the analytics and math while also doing something that's like talking about something that's like very socially acceptable, and you go into a room and like I can talk about it and like kind of be cool at the same time as nerding out. And like case in point, like this year I was in 5 fantasy football leagues.
Oh.
And I was like co-commissioner or involved in 5 of those leagues. So like, it's I won 2 of those. So it paid off, but that's a huge hobby of mine. And then I love hanging out with my family, my wife, my 2 boys, and I also love reading. Yeah.
All right. Oh, does your family ever ask you for random medical advice? We've all been there.
My family at large, yeah.
What's the weirdest question your family or friend has ever asked you?
Family and friends, it's more friends, but generally I get random pictures of poop.
Oh, no.
Baby poop. It's usually baby poop.
It's like, does that make it better or worse?
It just comes with the territory at this point. One of my friends has a really good rule. He said, he tells, his friends and family, like, I'm happy to try to answer as many questions as I can, in my ability, with my ability. But the rule is, if you're going to send me a picture, you have to give me a warning that a picture is coming. You can't just randomly do it so that like we're not in a Starbucks line and then random the picture comes up. I think that's really good advice.
That is a great rule.
A great rule, yeah.
All right. Any pets?
No pets.
Oh.
At some point, we're probably gonna get a dog because my youngest loves dogs, but none right now.
Favorite animal, not a dog or cat?
Peregrine falcon.
That is so incredibly specific. I love it.
Peregrine falcon, because of their dive speed. At one point, I feel like I remember this fact, that when a peregrine falcon is diving, they are the fastest animal in the world. Not land animal, obviously, but like in the dive.
I'm learning something.
I don't know if that is like decades old animal knowledge that might not be true.
Comments, help us out. See if things have updated. If you could have dinner with anyone in history, who would it be?
Ooh, that's a really interesting question.
Off the cuff, first one.
I would say it would be a Roman or a Greek historian. I'm thinking like Livy or Herodotus. I was a classical civilizations major, and I actually wrote my senior thesis on Roman army, like the leadership principles between a Roman general named Scipio Africanus and then Hannibal Barca in the Punic Wars. So Livy was the primary historian that I used, and I feel like talking to him would be kind of cool.
Well, what would you guys be eating at said dinner if you were to eat together?
Man, I feel like it's got to be some sort of Italian food.
Fits for the region. Yeah. What's your favorite dish to eat?
I actually, so I love, I'm Vietnamese. I love Vietnamese food. I love a good bowl pho. I actually love a good like bom dak bia bowl with like a good egg roll or chai yaw. I love actually like growing up, like my favorite dish was actually this Vietnamese dish called, it's called broken rice. It's gom tam bì.
Yep.
And I love that. So Vietnamese food, I could go on and on. I love Vietnamese food. My mom, I think, is one of the best cooks I know, and she usually makes our favorites. Bún riêu, bánh xèo, when I go home.
You're forgetting the classic, bún bò Huế.
Oh, yeah. We have bún bò Huế a lot. But like outside, like one of the comfort foods my wife and I make, just kind of like on our own, is mapo tofu.
That's a good one.
It's just a Szechuan dish. And then honestly, man, I could go on for, I'm like kind of a wannabe foodie. Honestly, breakfast for dinner is like sometimes something we default to, but like I think breakfast to brunch is like it's like this solid meal.
Brunch food is always a go-to. It's never too late in the day for brunch food.
Like a good hash, honestly, to me is like.
Okay, we could totally talk about this for forever.
Oh, 100%.
All right, coffee, tea, or soda? I think I know the answer.
Coffee, for sure.
Perfect. Well, I said we were going to move on from the food. Favorite meal from the hospital cafeteria, if you have one?
We have on certain Fridays, there's a really good clam chowder.
Oh.
I think that is excellent.
All right. Pineapple on pizza, yes or no?
It's okay. It's probably not my first order, but I'll eat it.
Okay. Safe answer. All right. I love this question because there's a reason why I frame it this way. It gives you so much more insight. Top 3 music albums.
Top 3 music albums. Oh, see, I'm honestly in this stage now of Spotify where I don't listen to I listen to radio or playlists that so if I'm talking about like lifetime though, like what have I listened to the most? Okay, this is going back, but honestly, between the 2 Linkin Park albums, like growing up, of Meteora and Hybrid Theory, or Hybrid Theory first and then Meteora, I mean, I don't listen to Linkin Park anymore, but like hours spent, like if I look at lifetime, those 2 are probably up there. The accompanying Fort Minor, Mike Shinoda, the rapper from Linkin Park.
Fort Minor.
Had a side project called Fort Minor, which I just love that hip hop kind of. Kanye has some honestly, I really likes Graduation.
Classic.
But I mean, right now, for the past 3 years, I've been listening to tropical house, tropical EDM, and I don't think my favorite artist or DJ I can't name an album. This is super long answer to say I don't know.
Look, that I ask it because you in order to like an album, you have to like every track on it. It kind of like if I said if you could get 3 albums on vinyl, because you don't get to choose, you get the whole thing, and you have to listen to it in order too. So I don't know. That's why I say it. Let's see.
Good question.
All right, we're getting close to the end. Let's quick fire some of these. Night in or go out on the town kind of person?
That answer has shifted probably in the past several years. Used to be go out, and now it's probably night in.
Indoors or outdoors?
Outdoors.
Beach or mountains?
Mountains.
Would you consider yourself more of an introvert or an extrovert?
I'm an extrovert.
And was that personality trait a factor in you choosing your specialty?
Yes. Definitely. Yeah, it takes a certain type of personality to deal with poop and puke and stuff like that all day. Gas, all day.
It's a very fair point. All right, so now we're hitting these reflective questions.
Yeah.
And of course, you absolutely have a platform speaking about medical education and advising the future students and really future pediatric GI doctors out there. So we're just going to dive right in. What did you think you were going to be when you grew up as a kid?
At certain points, paleontologist, teacher, and then improv comedian.
Oh, that's a spectrum.
Yeah.
That's a range.
Yeah.
Is there a different specialty you think you could have done?
No. Honestly, no. I've thought about it before, and I've gone through the cycle, and I'm like, man, could I have done another specialty? And honestly, I keep coming back to, why in the world would I, when I feel like I have the best job in the world right now?
Mm-hmm. If you didn't do medicine, what do you think you'd be doing right now?
I would love to be a food critic. Like, that would be sweet, traveling around to be a food critic. But honestly, the short answer is, like, with everything that just draws me, I would be a teacher.
Mm-hmm.
I don't know what I'd be teaching, but I would be a teacher.
Yeah. Now, everybody knows that the path to becoming a physician is difficult. It comes with its highs, lows, and buffaloes. Were there any times that you doubted that you would make it as a doctor?
Yeah. In my first year of fellowship, I experienced what is kind of classic burnout. And for the first time, thankfully one of the only times, I woke up in the morning for about a week being like, why am I doing this? Feeling directionless, feeling aimless, feeling upset and angry at the sacrifice, feeling like things that had brought me joy were just sucking energy and life from me. And I actually thought I, for a time, was ready to go to my program directors and say, this is not worth it to me. I even had that conversation with them, I think, of like, hey, I'm like I went through this, pre-contemplative at least, and they were, I think, worried and had me on, watch, not in like a punitive way by any chance and by any means, but I remember what it felt like. I called my best friend and was talking to him. He's in medicine too, and I remember that conversation, and I was like talking through, and I was like, I just feel depressed. Yeah, I feel like so tired and drained. He's like, dude, you are burnt. That is burnout. That, like, you are going through the depths of it right now. And I told him about my idea to like just go and just be like, I'm gonna do something else for my career. I'm like really thinking I won't make it. And he said, well, think about it, sleep on it. Like, that's a big decision. But I remember that pretty vividly. First year of fellowship.
And if you could change one thing about the medical field right now, what would it be?
I think my answer is very easy. I think that medical education is so amazing, and I want to amazing as an entity, and I want to be a part of it. But it is fundamentally flawed because of this still very archaic focus on the apprenticeship model. And I just went through this transition. I went through residency, went through fellowship, and now I'm an attending. And what happens is twofold, actually. These are closely related, but they're, I think, part of my answer. You don't get any training at all on how to teach, for the most part. You get training at, when you're moving from intern to second year resident on how to be a good supervisor, but it's like a little boot camp. It's like some programs call it as residents as teachers, and it's not enough. But you get to being an attending, and you're expected to supervise medical students. You're expected to supervise residents, give meaningful feedback, to talk about goals, expectations, to be able to help someone who's struggling, and you have no idea how to do it. And we're expecting people to, well, you're an attending now. You know, you should know.
You should know, yeah.
But we don't. We are not giving people the tools. We're not equipping them with tools to succeed. And we're just expecting that you went through the training, you should know how to do this. Well, we don't. We're trying to figure out how to be a good doctor for the first time, to be a practicing independent physician, let alone supervising, and encouraging and empowering and building people up. So we need to give people the tools for success, and very similar to that, we don't give people the tools for succeeding at their job. I say it all the time. Starting in pre-med years, you are thinking about your career and the rest of your life and the rest of your career. And you don't really focus at all on the job. So you go through all this school training, you get out, and you have no idea when you're about to find your job about how to negotiate, how to talk. You feel weird asking for certain things. You feel like you have no leverage. You don't know how to advocate for yourself. You don't know how to be professional in certain things, like even communication. And it's things that your friends outside of medicine are like, dude, I learned that at 22. Yeah. It's called a job.
Yeah.
And we don't work in jobs. Residency is not a job. It's still training. So we don't give people the tools to succeed in that professional arena either. I think those are the things that I would change globally about education. Yeah.
And just a plug, because I know we're going to film in a second. If you want to hear us elaborate more on that, there will be a whole podcast conversation about that. I don't know if it's going to be out by the time this goes out, but all right. Last 3 questions. First, what can a medical student do right now to prepare to go into your specialty?
I would reach out and find mentorship, regardless of my specialty or not. I would find mentorship wherever I could find it. And that mentorship may look different in different areas. That mentorship may not be the traditional research mentorship, but it's career, life mentorship, professional development mentorship, research mentorship, clinical growth mentorship. I would reach out and try to find whoever was in my area, and some areas have more access to pediatric gastroenterologists than others, but to be able to find someone who could say, hey, this was at least my experience. I don't know it's going to be able to be generalizable to yours, but here's at least some guidance to help navigate, because it's really difficult to navigate by yourself. But one of the cool things, plug for how amazing our specialty is, we have a society. We actually have a pediatric GI society that actually has a special event for second year residents. Second year residents will come and invited to the annual meeting, and they have a dedicated program every year that's sponsored, that has dedicated educators who are like talking about what's it like to apply to this specialty. Here are the steps you take here, and then they actually bring in speakers, and then you get to interact, and then you get to meet program directors. Like, I've never heard of another society, at least within pediatrics and maybe beyond that, going to the levels that our society does. So I would get plugged in. It's called NASPGHAN, North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. It's a mouthful, but finding more information about that program, which is called Teaching in Tomorrow.
And I really appreciate you giving like a specific example too for people looking for that. I'm sure I'll put links in the description as well for those. Now, if you were to go back, would you change any of your experiences that got you to where you are right now?
Absolutely not. Because of where I am right now. I could probably make tweaks, but it's like the butterfly effect. Like, if I could guarantee that I would end up with exactly what I'm doing, with the opportunities that I get to do right now, with teaching, with mentoring, with coaching, with even patient care, and how to tailor like life as a pediatric gastroenterologist who's maybe not as clinic oriented and inclined to more hospital and acuity based, if I could do something differently that gave me the exact end result, then yeah, maybe I could find some tweaks. But I wouldn't change a thing if like that was the only way to get to where I am now. Like, I wouldn't trade what I have now for anything.
Wonderful. And last question. What would you say to the aspiring pediatric gastroenterologist right now?
I think I would say, remember that it's about your patient. At the end of the day, remember that on the other side of all of this training and the hardships of training and education, there's a patient who needs you, who could benefit from your work, your time, your energy, and it's worth it. At the end of the day, if you even help one person, you've made a difference.
It's worth doing, right?
Yeah.
Well, Paul, thank you so much for just a lovely conversation. I know this is a lengthy one, but every single bit of it I thoroughly enjoy, and I hope those watching, whether it's in parts or all the way through like a podcast, gets inspired and sees a little bit of what it, at its core, what it means to be a physician. So thank you so much, Paul.
Thanks for having me.